We're discussing our Future Health UK Biobank Genomics England, exploring the impact. And this discussion is the first of three in a series looking at large-scale biomedical databases and research resources that PET is producing in conjunction with our Future Health. Simply put, these biomedical resources aim to enable health researchers to find new ways to tackle the growing burden of disease and to improve the health of entire populations. So these programs involve data-driven approaches, community engagement and partnerships, and to tackle complex health challenges and reduce the disparities that we're all becoming more aware that we face. And of course, they all involve painstaking scientific research. And PET is very excited to have experts from UK Biobank, Genomics England, and Our Future Health joining the discussion tonight. And I'd just like to say a few words about each project. So UK Biobank, which launched in 2006, is the most long-standing of the three projects. And to prepare for this event, I mined the BioNews archive, which has been going since 1999, and found that we've been covering UK Biobank since at least 2002, when Professor Sir George Rader, then Chief Exec of the Medical Research Council, told the media it's hoped that in 20 years' time we may see individualised approaches to disease prevention and treatment. The next one out of the starting block was Genomics England, and the 100,000 Genomes Project was announced in 2012, and Prime Minister David Cameron backed this project, saying this agreement will see the UK lead the world in genetic research within years. He added that the research would help deliver better tests, better drugs, and above all, better care for patients. Our Future Health may be the baby of the three, but it's the most ambitious in terms of its size. And when it launched in 2022, Professor Sir John Bell said, "We see this as a 10 to 20-year project. If we don't do this, the NHS and the healthcare system is going to collapse under the weight of late-stage disease." So our first speaker this evening is Professor Dame Sue Hill. She is the Chief Scientific Officer for England and head of the profession of the healthcare science workforce in the NHS and associated bodies. She is Senior Responsible Officer for Genomics at NHS England, where she has led the establishment of the NHS Genomic Medicine Service.
I'm going to be setting out the context, really, about how we take the evidence from whether they're disease-based studies in genomics or population-based studies into the National Health Service. So I'm just going to set out the infrastructure that we have, the mechanisms we have to affect change, and then how we're working with the different organisations as part of this conversation this evening to effect a change for our patients in terms of the evidence that's generated that can deliver significant benefits. So if I may have my first slide. My first slide just sets out what is the landscape within the UK and what makes implementing the outcomes from genomic-based studies possible in the context of implementing genomic medicine within the NHS. And this has all been informed not only by the earlier discoveries of DNA, but also the UK's significant involvement in the Human Genome Project. And I think, Sarah, you've really helpfully set out the role that UK Biobank, Genomics England and Our Future Health will play in this overall landscape. And as we look at what makes us unique, and indeed I speak to many different countries across the world in the context of genomics and the adoption of genomics. It's because of the strength in our research and innovation, and the three organisations that we have speaking tonight really exemplify that. The fact that we have an NHS that is a single payer system with longitudinal health records and other organisations that enable the NHS to adopt genomic discovery. We have a really vibrant life sciences industrial sector that work with the organisations that we have as part of the discussion this evening. And then we have the political and the health system leadership will. And on the right-hand side of this slide, you see the statement from the current Secretary of State, when not long after he came into post, when the Labour government came into power last year, which is the commitment to make the UK a life sciences medical technology powerhouse, but that the NHS is the best placed healthcare system in the world to take advantage of those rapid advances in data, genomics, and predictive and preventative medicine. As we look forward, genomics will have an important plater role in key government plans, including the 10-year health plan, the 10-year cancer plan, and the life sciences sector plan. If I can have my next slide, this just sets out the infrastructure that we created in terms of the NHS Genomic Medicine Service that was informed by the work that we did together with Genomics England to deliver the 100,000 Genomes project. And it really enables us to understand the infrastructure that was going to be required to enable the NHS to embed cutting edge technologies for patient benefit. So we have an infrastructure, and a lot of this infrastructure is actually nationally commissioned, and that includes within NHS England a genomics unit that sets the direction, sets the standards, commissions resources, and oversees the delivery. 7 genomic laboratory hubs, supported by 7 genomic medicine service alliances that is driving the embedding in of genomics into end-to-end pathways, a relationship through the establishment of cellular pathology genomic centres to speed up the pathway of cancer samples into cancer testing. And then this is underpinned, although they're not commissioned through the genomics unit at the moment, 7 integrated clinical genomics services. This whole infrastructure is underpinned by a genomics education programme and a partnership with Genomics England to support the delivery of now an NHS genomic medicine service, whole genome sequencing service. And what underpins the Genomic Medicine Service and its launch was the commitment to the alignment with research and innovation and to the continued population of the National Genomic Research Library. Essentially, we've created 7 NHS Genomic Medicine Service clinical innovation hubs, from testing and analysis through to the ability to undertake innovation, to support research and clinical trials, and really drive change in terms of end-to-end clinical pathways. And the geographies that these 7 areas serve are shown on the right-hand side. And you can see that across the bottom of this slide, this delivers key benefits for patients across the life science, a life course from non-invasive prenatal diagnosis right up to the earlier diagnosis of cancer, leading to more patients living longer and accessing, for example, precision medicines. If I can go to my next slide, this just sets out that in 2022, we published the first NHS genomics strategy with 4 key pillars. And you can see as part of those pillars, in pillar number 4, it supports evolving the service through the alignment with that cutting edge science and research and innovation. And it's been recognised, for example, through the Academies of Science in the US, that having a National Health Service allows for the uptake of genomics rapidly and at scale. And we're making good progress on the delivery of the 36 commitments within this strategy. My next slide actually just sets out that the offer to the citizens of England that access the NHS, so those 55 million people in our population, is set out in the National Genomic Test Directory, which sets out what is nationally funded in terms of the genomic testing offer, from single gene testing through to whole genome sequencing, and including RNA targets for cancer, as well as other biomarkers. So the test directory covers testing for over 7,000 rare diseases that are known to have a genomic cause, over 2,000 cancer clinical indications, some pharmacogenomic testing, and really recognising the importance in terms of the role that our genes have in terms of how we respond to drugs and whether there needs to be any adjustment in the dosing regimens. But also it supports testing as part of a precision medicine end-to-end pathway. The applications to this test directory are reviewed by clinical and scientific experts annually, and before a separate impact assessment is done in terms of the finance and any commissioning decisions. And a fast track system can be in place in year, and we've just really invoked this recently with a new bladder cancer medicine, so that we can introduce any NICE approvals for precision medicines when they require an associated genomic test. You can see on the right-hand side of this slide, it sets out that the testing is offered across the life course, which includes our national fetal whole exome sequencing service in the prenatal testing space, but also our rapid whole genome sequence service for acutely unwell babies and children. And this goes round the whole of the life course, but is constantly evolving as our scientific and technical knowledge expands, and from detection to management, but also importantly into that preventative and population health space. And you can see the Genomic Medicine Service delivered over 850,000 genomic tests last year, and the demand is going up year by year. If I can go to my next slide, which just sets out that we have a number of levers for embedding innovation. So from discovery research right through to routine clinical care, including inclusive of proof of principle testing and also translational research and clinical trials. And that's because we have policy and strategy that's delivered and aligned with key priorities. We have contracting, commissioning and finance in place with annual business planning and budget setting. We have that National Genomic Test Directory that's updated annually. We can, through that infrastructure I described, we can undertake pilot and research studies. We have, through our Genomic Medicine Services alliances, an integrated delivery network enabling the development of end-to-end clinical pathways where genomics is part of it. And we have that underpinning of national and local education and training of the multi-professional workforce, which is critical for the uptake and adoption. My next slide just sets out, as I start to go to the final part of my talk, is that a really important part of our relationship with Genomics England is the ability for their National Genomics Research Library to undertake ongoing analysis of the whole genome sequences together with the longitudinal health data they have there to find new discoveries And in an arrangement with NHS England, they can be fed back into the health system on a regular basis. And so far, nearly 4,500 putative new diagnoses have been returned to the NHS genomic laboratory hubs for validation, with only 85% of those being reported clinically as likely pathogenic or pathogenic. My next slide just shows how quickly any discovery, though, as part of this whole process, wherever that's done, can be brought into being. So this was some discovery work done on the National Genomics Research Library at Genomics England that identified an association between variants in the non-coding genes RNU4 or 2 and a neurodevelopmental syndrome. They were published in 2024 towards the beginning part of the year, so around April, May, and then July. By November, these genes were then incorporated into whole genome sequencing testing for a number of clinical indications and were on the test directory. So within a year and within months, bringing benefits for patients. And you can just see the quote from the parents of this young child. If I can go to the next slide. We work really closely with Genomics England on a number of different research and proof of concept areas. One of those is supporting them in the generation study, which aims to sequence 100,000 newborns. And I'm not going to steal any thunder from Chris Schonewald, but the reason I've put this in this slide deck today is with NHS England, Genomics England worked with us to develop pathways for 207 different conditions that included both the confirmatory testing following any condition-suspected result, an agreement on the intervention for these essentially, in some cases, asymptomatic babies, through to the care that would be provided within the NHS. And this will provide not only a resource for a lifetime resource of going back and analysing the genomes of these newborns, but also earlier diagnosis of patients with these rare diseases and a better understanding of how we manage these conditions within the NHS. If I can go to my next slide. This just sets out in terms of how we work together with Genomics England. So Genomics England contains consented longitudinal health data, as well as the NHS GMS whole genome sequence data, but currently no other non-WGS data. They have ethical approval and protocols to enable feedback on participants, and you can see I've already talked to you about the positive arrangements. With our future health, it will contain consented longitudinal health data, but not NHS diagnostic or genomic data. But ethical approval and protocols enable feedback on participants, and we're working with Raghib and the team at Our Future Health on how potential future service model evaluation studies can take place, such as on polygenic risk scores, and how we can jointly agree which results are fed back into the NHS instead of the NHS having to repeat those results. So a really positive step forward in terms of that more population-based health. In UK Biobank, although they have consented longitudinal health data, and included some coded primary care data for some of the participants, their ethical approval and protocols don't support feedback to participants. They do have genomic data that they've generated themselves. But on the right-hand side here, what we know is through the published evidence from UK Biobank, for example, some of the research that was performed on that database led to an update to the eligibility criteria for inherited breast cancer and ovarian cancer, which changed the age threshold for bilateral breast cancer testing, and the addition of testing for people affected and with Orkney and Shetland Island ancestry. So we can evaluate through all of these different partner projects the evidence that's generated through research to inform our commissioning decisions. My next slide just sets out, though, there's still things we need to do, which is how do we coordinate and inform the large amount of research activity and genomics and align it to NHS prioritisation and commissioning so patients and the public can benefit? How can we enable access to NHS genomic data, whether it's in GELS, NGRL or other TREs or SDEs that are part of UK Biobank, as well as federating data sets to make the resources more valuable? And how do we establish feedback and validation methodologies from these different studies to ensure they're performed to NHS standards? And you can see on the right-hand side that we're looking at specifically at how we can address these challenges, including conducting an annual synthesis of evidence generated from projects to make sure we've got a more strategic approach to applications to the test directory for adoption of the evidence. If I can go to my next slide, as we move towards the future, though, our data and digital developments will see us introducing a unified genomic record for every individual patient that undergoes a genomic test in the NHS. And that will be brought together with their other data, longitudinal health records, their diagnostic data, and a variety of other data. And that will be able to be accessed by the patient, by the health practitioners, by clinical scientists and researchers. And this will enable researchers to reach into that data if they have the right permissions and the access to use that to both search for cohorts, but also to access the data for research. So finally, my last slide just sets out the fact that we have to work together to really accelerate the use of genomics, including and with the Progress Educational Trust that provides that impartial and accurate information to people that are affected by infertility or genetic conditions, and really provides the platforms for them and relative experts and practitioners to discuss a range of really important developments in this area. So we thank PEP for what they do, and we have a long history of supporting these activities and our partners.
So our next speaker is Dr. Adam Lewandowski, who is the Deputy Chief Scientist at UK Biobank. Adam is an Associate Professor of Cardiovascular Science at the University of Oxford's Clinical Trial Service Unit and Epidemiological Studies Unit.
For many of you, this may be a refresher, but to highlight a little bit of where UK Biobank started, Sarah kindly introduced in the introduction how it's the oldest of the three that we're talking about this evening. But back in 2006 to 2010, 500,000 participants took part in the UK Biobank and attended for a baseline assessment when they were aged 40 to 70 years old. So on the right, you can see some of the assessment centers and where UK Biobank participants attended for this baseline assessment. So the way that they were selected around the UK was really to try to enhance cohort diversity as much as possible at the time, but to have participants that would be within about 20 miles of the original assessment centers. At this time, there was a comprehensive baseline data collection, including lifestyle and demographic information, as well as biological sample collection and physiological measurements. and really importantly was the consent to access all of their medical records and other health-related records, and the ability to recontact participants for further assessments. One of the big advantages of and success owings of UK Biobank has been its accessibility. So the research community has really grown over the last decade in particular, and we can see here the number of researchers now actively accessing data is around 20,000 researchers globally, with about 80% of them being international, so almost 60 countries globally. And to gain access, there is a registration process where they're vetted to make sure they are bona fide researchers. But importantly, there is an equal access model for researchers within university, charity, and government, as well as commercial sectors, enabling cross-disciplinary research and discoveries. And we've really seen now the impact as the resource becomes larger and larger in depth, which I'll go into a bit more. But we've now got about 15,000 publications as of the beginning of 2025. And we're seeing about 10 to 12 papers published per day using the resource, with almost 2,000 patents now actually around the world using UK Biobank data. A big aspect of why we've seen these increased in publications and also in terms of the number of active researchers has been because the resource, in terms of its depth, the data collection on these participants has really grown over the last 10 years in particular. And I want to highlight that at the end of the 2010, when the 500,000 participants were recruited, data then became available in 2012, where there was about 1 terabyte of data. We've now got nearly 40 petabytes of data available. And that's really owing to some kind of landmark time points. In 2017 was the release of the genotyping data, and subsequent then development of different polygenic risk scores and enhanced polygenic risk scores. And then the whole exome and whole genome sequence on the whole cohort in 2021 and 2023, respectively, and this data being available to the research community. In 2014, on the bottom left, you can see the launch of the world's largest imaging study, and this was a repeat of the baseline assessment in 100,000 of the original 500,000 participants, as well as multi-organ, multimodality imaging, including MRI, DEXA scan, and ultrasound. And excitingly, we're going to be reaching that 100,000 participant landmark at the beginning of July this year. We've also got a repeat of this imaging project that was launched in 2023, which will be up to 60,000 participants completed by the end of 2028. So it really was transformative when the genotyping data was made available to the research community. We've seen a lot of examples emerging now, especially using polygenic risk scores derived from GWAS data that we can. This is a paper coming from shortly after the data were made available, looking at polygenic risk scores and how they can be used to discriminate between patients with type 1 versus type 2 diabetes. And this studies showed that approximately 40% of individuals with a genetic risk of type 1 were misclassified as having type 2 diabetes, and that, of course, could lead to incorrect and ineffective medication from clinicians, given the fact that these are very different conditions. So it gives an example of how clinicians may be able to use these polygenic risk scores in combination with other data to better manage patients. And a recent work that's been part of an NHS pilot to determine the added value of adding these genetic data and polygenic risk scores to standard Q risk measures, looking at future risk of coronary artery disease, has shown in the pilot that GPs reported they would have changed the management of patients in about 13% of their patients as well. And these just highlight the motivation that really led to forming different consortiums to look at, to create data available to the research community to look at whole exome and whole genome sequencing. As mentioned, whole exome sequencing data became available in 2021, looking at the coding regions of the genome. And this was really led by Regeneron in the first instance, and then bringing on board different pharmaceutical partners. But the data that they generated with their expertise has been made available to all researchers that have access to UK Biobank data or registered users. To highlight here is that really the power of this kind of massive scale exome sequencing to look at different rare variants and genetics that you wouldn't be able to get from genotyping data has led to the idea that the inhibition of GPR75, for instance, could be a therapeutic strategy for obesity. And like I said, really does illustrate the power of massive scale exome sequencing for the identification of large effect coding variant associations and drug targets for complex traits. In 2023, as mentioned, all data were made available for whole genome sequencing, and this again exemplifies the partnership that took place between the pharmaceutical and charity and government funding to be able to make this happen and make these data available for the research community. And the sequencing was done by the Sanger Institute in Cambridge and Decode in Iceland. I want to highlight another example of taking this sequencing data from whole exome sequencing, looking at rare genetic variants of causes of familial hypercholesterolemia, where a replication using UK Biobank data showing the risk associated with carriers and non-carriers, looking at coronary artery disease, and highlighting that the combination of the data with the really high quality health outcomes data that we can add in through linkage to the NHS records allows us to look at these outcomes, combine it with the genetic information, but also combined with the extensive amount of information we have collected on the participants to look at what happens when we combine it with a healthy lifestyle score and look at the graded changes when different adherence to lifestyle or improved lifestyle choices lead to a more favorable risk of long-term coronary artery disease, which may be used in future for things like designing potential lifestyle interventions, but also in terms of clinical support and decision-making. Of course, with the imaging project, what we've started to see is people combining the data and looking at the data in new ways by the scale of the imaging data that's collected in combination with this genetic information. So using the GWAS data, for instance, we've started to see how brain MRI images, which will be available in all 100,000 participants towards the end of the year, have been used to look at how individual SNPs relate to changes in brain structure and volumes, but also in terms of function and brain connectivity as well. A recent study demonstrated the use of GWAS data in combination of the cardiac MRI data as well, looking at how we can take this MRI cardiac images from participants. This was done in nearly 50,000 participants, create 3D models to capture the full shape variation and morphology and structure of the right ventricle and left ventricle chambers of the heart, and look at how GWAS can predict these different variations created in terms of the morphology. Why this is important is that there were about 43 different loci that were identified as being relating to these unique variations in cardiac structure, with about 15 novel cardiac traits that were defined, and that these structures and genetic variations also associated strongly with cardiometabolic disease as well, again exemplifying the cross-disciplinary modes of data collection that allow for more research discovery. As UK Biobank ages, one of the major natural things to occur is that disease numbers start to increase as well. And now that the cohort is coming up to a mean age of 73 years, we're starting to see an increase in the number of cases of different conditions and different diseases as well, offering opportunities for us to study these individuals over time using longitudinal data collection, but also exposure outcome analyses, but also offers the opportunity for us to design new enhancements, looking at risk factor characterization, but also in terms of health outcome characterization, such as extending assays conducted on storage biological samples. So we already have pilot studies in proteomics available on 55,000 participants, where we've seen the incredible combination of that genomic and proteomic data. We're now extending this across multiple time points and the full cohort, so you'll have 600,000 samples covered as part of the Pharma Proteomics project. Later in the year, we'll also have availability of the NMR metabolomics data for the entire cohort. So again, starting to see these cross-omics discoveries and the opportunity to start identifying novel pathways that may then be translated into the NHS and tested in other cohorts in the future as well to validate these measures. And finally, just to mention that the enhanced health outcome characterization, we're looking at how can we link this information with existing medical data. So things like the pilot that we're doing at the moment and starting looking at cancer digital histopathology data, but also specific assessments that we can potentially better characterize to help with subtyping of people with known disease or symptoms as well. So to summarize, it's essentially that what's made UK Biobank so unique is the fact that the combination of these four factors, so the scale, it remains one of the larger cohorts, not the largest cohort, but one of the larger cohorts, but in combination with the depth and duration of follow-up now and its accessibility as well. And just to acknowledge, of course, the core funding from the top group cluster at the top, but also to the range of pharmaceutical partners that have helped make data available to the research community, so that those partnerships have really helped from that perspective, as well as the philanthropic funding as well. And finally, none of this would be possible without the incredible UK Biobank participants who have now dedicated much of their time for almost 20 years now as part of the study.
Next, we have Chris Schonewald, who is Chief of Staff and Director of Strategy at Genomics England. He was previously a private secretary to two successive Secretaries of State for Health and Social Care.
I'm not a member of all of the cohorts like C may well eventually be, but I'm a participant in our Future Health, so I've managed to tick one of the boxes for the group. This afternoon, I'm just going to walk through a few pieces. First off, a bit about Genomics England's history and our vision for the future, a bit about our work and how we deliver impact, and then two specific examples of impact, although I will skip over one because Sue has very kindly covered the RNU42 gene coding discovery earlier, but I will flag the Sunday Times article in that moment on that. A bit about Genomics England's history. We were founded in 2013 to co-deliver the 100,000 Genomes project with NHS England. Lord Cameron stood in front of Downing Street and launched and established the body. And the 100,000 genome was sequenced in 2018. And we continue to reanalyze those genomes on an ongoing basis. So it's not that ends the benefit to those people, but the data is still there. We then supported the launch of the world's first whole genome sequencing service in the NHS, which Sue kind of walked through the infrastructure very wonderfully earlier. But that's like a key component of the work that we do at Genomics England, because the data we collect in that healthcare system comes back into the research side of our services. In 2023, we've collected 80,000 images to support cancer research. So this is radiology and pathology images, which we put alongside clinical and genomic data. And this is part of our starting to use artificial intelligence and doing proof of concepts on what the benefit of those multiple modalities of data might be. And in 2024, we collected the first genome from the generation study, which again, Sue kindly referenced earlier. And all of this is about delivering genomics on a national scale. And really, what we like to think about this is our shared vision with the NHS of a world where everyone benefits from genomic healthcare. And I want to linger on that word everyone in that for just a second, because as you saw in Adam's presentation, this is a real global endeavor. It's an international endeavor and actually involves a huge amount of different bodies, different people, different skills to provide this in an accessible and equal way to everybody. And actually, that's about equality of access in healthcare, but also ensuring that our data isn't biased and that the research we do is of a broad spectrum of benefit. We deliver impact at Genomics England through what we see as a virtuous cycle. And Sue had a smaller version of this on her slides earlier as well. And this is about creating an infinity loop where delivering better health supports world-leading research. And so when we do a whole genome on a patient, not only do they get the results of that whole genome sequence back, their data also sits in the National Genomics Research Library, which thousands of researchers access from industry and academia and the NHS to then provide insights from that research back into healthcare. And this works on a few levels. So one is that diagnostic discovery that Sue described earlier, where you get a new diagnosis back to a patient who originally had their whole genome sequence and not had a diagnosis. But it also works with things like thinking about innovation, where you can think about driving innovation in research, feeding the insights of that into healthcare, but getting feedback loop back into research to think about different applications of it. And what we envisage through the use of this system, and this has been described by actually multiple people so far on the panel, is that we'll start to see genomics being applied across the lifetime. So I'll talk a bit more about this later, but there's newborn screening at the start of life that we're now piloting and working through the generation study, co-delivered and co-designed with the NHS. Adam referenced risk scoring and combining that with Q-risk scores around cardiovascular disease and the NHS pilot on that as well. And you can see that in the middle columns of this image. And then also we can start thinking about how we prescribe treatments and therapies aligned with someone's genomic makeup to ensure that those therapies are effective for that individual. And that could be an area of huge growth in the next 5 to 10 years and could be a really interesting new application of this. There's two areas of impact I specifically want to cover on Genomics England. The first of which is the generation study, which I think is a really nice example of the UK taking a real big leadership role in an area. And actually, lots of different countries want to do this kind of study. Apologies, my slides are skipping too fast. They want to do this kind of study at scale with a large cohort. And we're aiming to find some of the 9 children born each day in the UK with a rare and treatable genetic condition. And we're expecting 1,000 conditions to be returned to the NHS. And alongside that, we're looking for 209 conditions at the current time. We've hit 9,000 newborns recruited as of, I think, earlier this month. And there are 29 NHS sites delivering across the country who are doing this great recruitment work. And huge thanks to the people in the NHS who do that frontline work for us at moments of high stress. I just want to touch on a quote which I really liked from one of the participants in the newborn study, which is, both my husband and I felt that contributing to the research was important. Once we realised that our baby's genome could be used to help others, we put our names down and very much wanted to be part of that. I think it's a really nice reflection on the altruistic nature of some people thinking about other babies as well as their own who will benefit through the study. The second example is one which came about because of that reuse of data in the National Genomics Research Library that Sue described. That thinking about the reanalysis of whole genomes from healthcare. And this work was done by 2 research studies which kind of almost discovered it at the same time on RNU42, which the participants actually came up with a name for a new syndrome. And Sue talked about the impact of this earlier, the kind of 1 in 200 undiagnosed children with neurodevelopmental conditions are expected to be impacted by this. But also hundreds of people in the UK and the US have also benefited from the diagnosis. And the image on screen right now is the Sunday Times article by James Coney, which is a wonderful read. And I would really recommend it. It's a beautiful story about the impact and power of information and the relief that his family felt from the diagnosis being provided to them. And it gives that really nice human side to the data that we kind of see in the research environment, and that really kind of almost emotional impact as well as the clinical impact more broadly. The final thing I want to flag was just a few areas which are quite interesting coming up in the future that I think are things that will impact how we deliver using genomics, but also may impact how we engage on the topic as well. So think about new sequencing technologies, and that could be driving new types of data, new hardware that has a different footprint, which means we can put it in different parts of the clinical care system. It's artificial intelligence and big data. So Adam referenced there's 40 to 50 petabytes of data in UK Biobank. The use of artificial intelligence, the availability of high-powered compute and data centers now means that we can drive so much more and do so much more data work at scale across these large data sets. When our future health is at scale, for example, this will be hugely powerful for their population health research. The third thing I want to touch on is public dialogue and new ways of involving patients. So this is thinking about how do we do consent for research? We need to move away from paper forms. What's the digital front door for patients and participants into research? How are we co-designing it with them to ensure that they feel comfortable? And how are we working with the public to manage their expectations around what they will get from genomics and what they'll receive back from these big public investments that you kind of see sitting across the panel, which tots up to quite a lot of taxpayers' money. And then finally, just thinking about the movement of genomics beyond secondary care but into primary care. And I know that the NHS has set a really good genomic strategy that will kind of see the universal genomic record delivered that will then enable this shift from this secondary care into other parts of the care system so it can impact more people in more bases and bring that wider benefit across the lifetime that I touched on earlier. That's what I wanted to say, except a quick thank you to the NHS, who deliver a huge amount of the data to Genomics England and do that frontline recruitment as well in lots of the different studies that we do, and our participants at Genomics England, who rightly hold us to account to ensure we're using the data securely, safely, in all the right ways, and also provide these great stories to us to be able to show the benefit and the impact of the different work we do.
So following on now from Chris, we have tonight's final panelist, Dr. Raghib Ali. Raghib is Chief Executive and Chief Medical Officer at Our Future Health, and he's a consultant in acute medicine at Oxford University Hospitals and honorary consultant at the UK Government's Office for Health Improvement and Disparities.
Our Future Health, as was mentioned, is the kind of the baby of this trio of studies. Actually, I did work on UK Biobank right at the beginning. It was too young to join. That was 20 years ago. So I was happy to be able to join Our Future Health as a participant as well. You mentioned at the beginning the quote from John Bell and why this study was set up. And some of the, I won't go through all the points on this slide, but we really are facing very large public health challenges across the world and including the UK as populations age, but also with increasing levels of disease in older age, multimorbidity, but also working age populations, particularly mental health conditions, obesity, etc. And finally, we have these very large inequalities across the UK in terms of output, particularly by deprivation. As Sarah mentioned, in terms of my clinical background as a consultant in acute medicine, so I mainly have worked in A&E, seeing patients with heart attacks, strokes, cancers that have already spread, advanced dementia, etc. So very much at the right-hand end of this diagram. And this is our current model of care. This is how it's been really for decades. And this is neither good for patients because, of course, it's too late to certainly cure the disease, but even to have a good outcome for those patients. But it's also not good for the system. And the system really is struggling to cope with this demand. And so we want to find new ways to help improve both the outcomes for our patients, but also to reduce demand on the health system to make it more sustainable. And so this is what we're hoping to achieve through Our Future Health, is to establish the evidence base for this new model of care. So we identify people at high risk of disease much earlier, ideally diagnose this disease much earlier in the natural history, and intervene earlier in the pre-symptomatic phase to increase both lifespan, but also healthy life expectancy, which really has plateaued, if not fallen, over the last few years. There are a number of new technologies which are newish. Some of these have been around for a while, but they're not routinely used in clinical care. And although we've said for many centuries or a long time that prevention is better than cure, we do need better evidence base for many diseases as to how we can prevent them. And some of the tools on this slide I mentioned, I won't go through all of them, but for example, polygenic risk scores may provide a means to identify people at high risk much earlier, and then combined with other risk factor information, we can use that to intervene earlier for those who are at highest risk. Similarly, for early diagnosis, particularly in cancer, circulating tumor cells and circulating tumor DNA, and for early therapies, so this will be a combination of pharmacological and non-pharmacological interventions, particularly digital interventions, which are now possible with new technologies and delivered through smartphones and virtual coaches, etc. So these are all the types of things which we would like to test within our Future Health. Our Future Health was launched or announced in 2019 as part of the life sciences industrial strategy. So collaboration between charities, academia, and NHS and life sciences industry, designed to help people live longer, healthier lives, as I said, focusing particularly on prevention, early detection, and improved treatment of disease. It is somewhat unique in its being designed as a kind of private-public partnership right from the beginning. We had initial funding from government, but then more than matched by industry and charities, and now additional investment from government through UK Army Office for Life Sciences. You can see there we work with a number of UK-based charities, international life sciences companies, and also have many affiliate charities that we work with. And crucially, our partnership with the NHS, both in terms of recruiting participants into the study, but also going forward, as he mentioned earlier, the opportunity to work with NHS on giving people feedback about the risk of disease and integrating that into clinical care in the future. Just briefly go through the 4 key aims of the program. So this is all about establishing a better evidence base for these new approaches to prevention and early intervention. First thing is to build the resource, and similar, we've learned a lot, of course, from UK Biobank in this respect, building a resource that is accessible to researchers for both discovery and translational research, so across all sectors, including academia, charity, and commercial researchers. We want to do that on 5 million people. I'll come back to one of the main rationales for that, but for any prevention study, you do need large numbers of participants because most people won't develop a particular disease. So if you're interested in particularly, you do need very large numbers. We do want to be able to give people information about their own risk of disease, combining both genetic and non-genetic information, and to improve our screening programs, which are currently very much based on age, but to use a more risk-stratified approach where we can identify people who are at younger age who are at increased risk because of both genetic and non-genetic risk factors, but also people who are older age who are at less risk and maybe don't need to be screened as frequently. So it'll be a more efficient use of our screening programs. It can be extended to additional diseases beyond those where we currently have programs. Crucially, everyone that joins our Future Health also consents to be recontacted for future studies that can include clinical trials, biomarker validation studies, etc., and recall by genotype, recall by phenotype, to have additional biosamples taken, additional questionnaires, etc. And finally, because it is such a large resource, with 1 in 10 of the UK adult population joining the study, it will provide an opportunity to get unique insights into the health of the whole population, but also the impact of interventions and policies at the individual level that are from government or from local authorities, etc. So just in case anyone hasn't joined our Future Health yet, this is what the participant journey involves. So you sign up online, consent online after reading the information sheet, fill in your questionnaire online, and then attend an appointment to give a blood sample and some basic physical measurements. As everyone consents also to link to their linked NHS records across all 4 nations, including the devolved nations. And that's, of course, crucially important for these kinds of studies to look both retrospectively and prospectively. And this is really a unique strength of the UK, where we can do that at scale, which is not really possible anywhere else in the world. So our baseline, our phenotyping is relatively simple, certainly compared to UK Biobank. So the baseline questionnaire, the custom genotype array, and the data linkage, and the basic clinical measurements. But we do have the opportunity to go back to our participants to collect additional data, but also to link to additional data sets. So we're very pleased that primary care data is going to be available later this year, that we'll be able to apply for that, as well as other data sets, and including administered data sets in the future, like the census, for example. As we can also go back to participants to collect additional data, for example, cognitive function, or to collect data from wearables, and to do additional analyses on the stored samples, so including whole genome sequencing, methylation, proteomics, metabolomics, etc. One of the other priorities for us at Our Future Health was to ensure that the cohort that we recruited was more representative of the UK population, and particularly with those groups that had historically been underrepresented. So that includes many parts of the UK which just haven't had the opportunity to take part before because they weren't near a university town that run these kind of studies, or a clinic. In terms of age, most cohorts have been kind of 40 plus, not just in the UK, but globally. In terms of ethnic diversity, again, most non-European ancestry groups are underrepresented globally, but even in the UK, there's certainly not underrepresentation. And finally, by deprivation or socioeconomic diversity. So given that the most deprived quintile have by far the worst outcomes, it's critical that they're represented in this kind of study, so the research we do can help improve their health, but also can help to reduce inequalities. So we launched recruitment in October 2022, so about 2.5 years ago now. Since then, we've opened over 400, we've had over 400 venues, a combination of community pharmacy, working with booths, as you can see there, mobile units, going mainly to supermarket car parks, but also many other places across the country, and various shopping centres. We really try to make it as easy as possible for people to attend an appointment. So generally, we try to provide a clinic location within 5 miles of where people live, and that's really been possible with this approach. And you can see on the next slide that has led to really an unprecedented response from the British public to join a study like this in such a short period of time. And really nothing like this has been possible globally either. So you can see the various figures now. Over 2.4 million people have already consented, about 1.8 million people have completed their questionnaire, and over 1.4 million people have given a blood sample. And the full participant is someone that's done both consent and has completed their questionnaire and given a blood sample. So this is what was mentioned right at the beginning. I think we are the world's largest consented cohort with stored blood samples now, and that's obviously an important resource for researchers across the world. So you can see here the location of our participants. So on the left are those people who have full participants. On the right are those who are consented. So we haven't got clinics across the whole of the UK yet. So we've started recruitment in areas of higher deprivation and ethnic diversity in England, and then moved gradually across England and then to Scotland, Wales, and not yet in Northern Ireland, although we will open clinics in Northern Ireland later this year. And you can see really for the first time, that we have got in a UK study participants from every single town, city, village, island of the UK, which, as I said, is one of our aims to make it as accessible as possible. In terms of the demographics of our cohort, it's not perfectly representative by census, and we never expected it would be, and it's not possible to do that. But we have managed to get very significant numbers of people from those underrepresented groups. So over 500,000 people aged under 40, which is by far the largest cohort of that size in the world of any type. In terms of non-British white, about, again, approaching 20% of the cohort are non-British white. So about 400 and something thousand people there, and over 250,000 people from the most deprived quintile. So really for the first time, we have an opportunity to study those populations, but also understand the differences in outcomes based on the data that we've collected. In parallel to devoting a lot of time and resources to recruitment, we have also tried to make data available to researchers as quickly as possible. So we set up a trusted research environment that launched about 18 months ago, so quite soon after, within a year of recruitment. And over the last 18 months, you can see really a very large amount of data is now available to researchers, so you can apply online from that website. We have over 1.5 million questionnaire data and nearly that much NHS England secondary care data, and over 1 million clinical measurements and genotype data on the first 650,000. We have, as you can see here, a few hundred researchers now accessing the resource and about 30 odd studies who are already in the TRE. And a nice milestone recently was the first paper that was published on medRxiv using our data on mental health disorders and chronic inflammatory conditions. So we have a long way to go to catch up with other studies, including Biobank, but we're happy to have the first. Looking ahead, so these don't all increase at the same pace, as they're already at 1.5 million questionnaires. But by the end of 2026, we aim to have 1.5 million participants with all of these data types in our TRE and accessible to researchers, and then increasing roughly by 500,000 every year going forward. So again, to maximize the opportunities for researchers to use the data and to make those discoveries that we want. Just before I finish, going back to why we need a very large cohort. So you can see, this is looking at cardiovascular disease. If for some disease, you get really very large numbers of participants within 2.5 years, incident cases, even at the size of the cohort currently, around 2.5 million. And once you get to 5 million, then very significant numbers. But of course, there are many diseases which are not that common, and previous cohorts have been really too small to be able to study. So, for example, on the next slide, you can see some of these cancers which are significant causes of mortality, for example, pancreatic cancer. With any cohort less than about 3 million, it's really quite difficult to study these diseases in a timely manner. So our future, hopefully for the first time, we'll be able to look at cancers, the less common cancers, but still very high mortality conditions, as you can see there, which again have high morbidity, like Crohn's disease, polycystic ovarian syndrome, endometriosis, lupus, epilepsy, Parkinson's disease, multiple sclerosis, motor neuron disease, and pulmonary fibrosis, etc. So these are all diseases which have a significant burden of morbidity and mortality. And we're very hopeful that with this cohort, as I said, we can really have an impact on understanding both the etiology, but also which interventions can prevent them in the future. So just to end with a summary of some of these unique opportunities, of course, with our Future Health as a recent study, we can't talk as much about the impact to date, but these are the opportunities we will have going forward. I won't go through all of them, but just to maybe mention, given this is, because we don't focus on genetic opportunities with genetic risk factors, so we want to develop and assess integrated risk scores, combining polygenic risk and other risk factors to improve identification of people at higher risk. And that can also be used for recall by genotype and recall by phenotype studies, and also pharmacogenomics. And finally, can't give a talk these days without mentioning AI, of course. So we have the opportunity with this very large data set to really use AI and machine learning to improve the prevention, detection, and treatment of disease. I think my last slide is just to say, and this is our aim, our ambition for the coming years, to enable everyone to live longer, healthier lives. So
I'm going to go with the most popular question first, which probably not unsurprisingly is a political one. And that is, what impact does the abolition of NHS England have on this work? I don't know how much you can comment on that, Sue, but I'll go to you first.
Okay, thank you, Sarah, and thank you for the questions. And just to say thank you to my fellow presenters for excellent presentations this evening. Obviously there is the Genomic Medicine Service I outlined is a commissioned service and funded by NHS England. So that function will need to be continued. How that gets delivered under the integration of NHS England into the Department of Health is something that we're still working through. But it is still a service, a clinical service that is required for the NHS and would continue. And we expect the 10-year plan, the life sciences sector plan, and also the 10-year cancer plan to all recognise the increasing role that genomics will play in clinical care and in outcomes, especially in precision medicines and their use.
Thanks, Sue. Does anybody else want to come in on that? I'm guessing not. Okay, so the next question is from David Seymour, who asks, what role and or benefits do the panelists see for their organisations in the proposed Health Data Research Service announced at the start of April by the Prime Minister, especially given the involvement of Wellcome and the plan to host it at its Genome campus at Hinxton? So I don't know which of Adam, Chris, and Raghib would like to go first on that one.
I'm happy to go first. I think
Yes, sure, Chris.
it's a really great announcement. I think it's really welcome funding in an area that needs that consistent funding to ensure it can deliver and have that security of timescales, because it's a massive piece of work, coordination data across not just the NHS but also these wider consented bodies, and think about how we'll work together with that new body. It's also really helpful because it helps set standards. We'll have a central body that can help with accreditation of security and set some of those fundamental pieces at the core of the system that really need to be in place for everybody that will hopefully help coordination. I think the interesting part is going to be how they set it up. So what's the infrastructure going to look like in terms of the data being held at local level and the HDRS being a platform on top of that and representing that out? Or are they going to draw more of the data centrally and then work on it there and then again reflect that outwards as well? And I think we really welcome it at Genomics England, actually, because it's been an area where it has needed that really front-footed funding to show that we can work with it and coordinate, and it's really a positive step.
A positive step, Adam? UK Biobank?
Yeah, definitely. So it's been well received by UK Biobank, and I think Chris touched on most of the points, but I think really that coordination and that security and funding investment into this to support kind of linkage to studies and supporting how we can enable this discoveries, but also then kind of translation approach back into the NHS as well is really fantastic.
And Raghib, are you looking forward to working with them?
Yes, no, we are. Just to say, we are equally supportive of this. It's a complementary resource. Having an anonymized database of all 68 million people in the UK would be unique, really, globally. So yeah, very, very much supportive.
Great. Okay, the next question is for Catherine Ramsey, and I think sparked by something that Sue said. She says, I'm a Biobank participant, and advice from Biobank was that better for data not to sign up to Our Future Health. Is that still the advice? Professor Hill said she is a UK Biobank participant, yet to sign up to Our Future Health, but will. So Adam, can you take part in lots of these, or are we mucking up the data?
I'll start off by saying that I'm a participant in Our Future Health, but I think yes. So the position is scientifically, of course, the best situation would be able to test independently in UK Biobank and also Our Future Health. But of course, we're very supportive of the project and are supportive of people making the decision to take part in both studies as well. So I think I think it's a fantastic initiative, and seeing that people taking part and just seeing those numbers go up, as Raghib has highlighted for Our Future Health, is very exciting to see as well.
And Raghib, I'm guessing that Our Future Health, I don't know whether you even asked if people have participated in these other things, and do you have a policy on it?
So, I mean, of course, it's up to every individual what study they'd like to join, and so we don't give advice to our participants either way. It's their choice, of course. But to the specific question, we don't ask people whether they're part of these previous studies, but we have got some data which suggests the overlap is actually very small, from another question that was done by another study where they asked about who had participated in Our Future Health and UK Biobank. And one of the reasons the overlap is small is because the age range that we have in Our Future Health is much wider. So it's 18 plus. Also, the geographical location is much broader. So my guess is that it's less than 5% of the cohort, which is overlapping, and probably significantly less. I think that's the maximum that it would be of the people that we have within Our Future Health. And I understand the rationale. As I said, I worked on UK Biobank myself. As a purely observational study with no feedback, there was a concern that if people join Our Future Health and start to receive feedback, that could contaminate some of those kind of observational analyses, so we understand why that advice was given. But as I said, in terms of the general public and participants, we would encourage them to make a decision based on their own, views.
Great. So, Catherine, the ball's back in your court, whether you want to sign up to Our Future Health. So, I think, having heard Raghib, you're probably keen to do it now, I suspect. Right. So the next question is from an anonymous attendee who asks, are there enough qualified staff to work in the NHS Genomic Medicine Service, or are there shortfalls in staff in the same way that there are in other parts of the NHS? And what is being done to ensure that the right staff are available to meet the demand, which is likely to increase massively? So I think, Sue, perhaps you're best placed to answer this in the first instance.
Yeah. So we have a very focused set of activities around the workforce that's required to deliver the service. At the moment, the number of vacancies in the service are lower than they have been for some time. There's always challenges about recruiting to areas such as bioinformatics, but within the NHS and within the NHS workforce training and education part of NHS England, we've worked very closely to try and match demand with capacity and the supply pipeline of trainees into the system. And as such, we've increased the number of trainees going into the system. And it's an ongoing annual activity to look at the supply, the demand, the capacity, and to model that on an ongoing basis. So as we move forward, and I didn't have a chance to talk about this today, as we move forward, it won't be all about increasing the number of people we have. It will be about how can we become more efficient in delivery. So industrialization and automation of processes, and also using AI and other automated analytical pipelines. That means that you use your highly qualified staff in different parts, in different ways within the system, particularly in the clinical interpretation of what's going to become increasingly complex genomic data that needs to be interpreted in the context of the clinical phenotype. So I think it's a live and topical issue, but it's one that we never have a shortage of people who want to come in to working in genomics in the NHS. And I think that's because our universities are still providing graduates in this area. And there's always an interest in using those skills in health and being sort of able to be more frontline in terms of the delivery of a service that has a benefit to a patient.
Yes, and I suppose as well the genetics education program, which is, everyone can take advantage of, is a good way of people just generally upskilling their knowledge of genomics as well, isn't it? So
yes, it's really the specialist workforce, but we have different ways of also training staff. We have a genomics training academy now. We're using virtual training where people use virtual training methods to actually even walk around and participate within a laboratory without even being in the laboratory. So I think novel ways of training people too, that means that we can increase the number of trainees without always needing the capacity on the ground to train in person.
Okay, I'm going to move on now to the next question, which is from Mark Bartlett, which says, given the recent bankruptcy faced by 23andMe, a company with over 7 million genotyped individuals, do you see this as a signal that array-based genetic testing, such as that used in Our Future Health, may have limited long-term value compared to the more comprehensive whole genome sequencing strategies employed by Genomics England and UK Biobank? Considering Our Future Health's target of 5 million participants, which is smaller and less globally diverse than 23andMe's dataset. How can the UK ensure that this investment remains competitive and impactful on the international stage? So that's one directly for you, Raghib.
So in terms of the initial decision, for a cohort of our size, to do whole genome sequencing would not have been affordable from the beginning. So it was really a cost issue that we needed to start with a genotype array. And the other point is that our future is not just interested in genomics as a risk, as the only risk factor. Of course, for most diseases, genomics can be a significant risk factor, but it does vary, depending on the disease. And it's only having a comprehensive overview of all risk factors. So what we collect from our questionnaire, from our physical measurements, from the NHS data, particularly once primary care data comes in, that you get that much better picture of what is both causing disease and also potential opportunities for intervention. So 23andMe never had the other data, which you really do need. Genetic data on its own is really not that useful because, as I said, most diseases have multiple risk factors which are not genetic as well. Having said that, of course, having whole genome sequencing data provides additional opportunities for research, and particularly in target discovery and rarer diseases where the genotype array may not have, or rarer mutations available, although we do have some markers on our genotype array. And so it is likely, particularly as the cost of whole genome sequencing has come down significantly and will continue to do so, that we will sequence our cohort as well in the coming years.
Great. Does anyone else want to come in on that? I think it was really a question for Raghib. Okay. So more of a general question, really. Does anyone else worry about the increasing use of genetic medicine exacerbating health inequalities due to social circumstances? Do we think, are people going to be left behind here? I don't know whether people have given this thought. If Chris, have Genomics England given this much thought? And then I'll go to Sue.
Yeah, so we've done a bit of work in the Serenar Diverse Data program where we specifically wanted to think about addressing health inequalities or work towards it. You can never do it through one program. And so we work with on sickle cell and other areas that are particularly impactful in certain demographics of the population. And we did lots of work with those communities, thinking about how to engage with them. And actually, again, on the generation study, we had a similar thing where we worked through our materials, did lots of user research, thinking about having those all in different languages, the different ways people want to engage, whether that was paper, whether that was digitization. And so really trying to give people the right pathways to get involved that works for them, essentially, to ensure that broader spectrum can get involved in research. The challenge is always going to be that we need to do a lot of work to make sure the data is representative. So in the generation study, we have said that the target is to make sure that the data at the end represents, in terms of demographics and ancestry, the UK population, so that people are represented within that data set. But it's an interesting concept for global genomics, actually, where you probably will see richer nations taking over and doing more of this work at scale than others.
And Sue, I think you wanted to come in.
So I wanted to come in terms of the healthcare component rather than the research component, because I do think there are many different studies that are really looking at ensuring that they've got that their research cohort is representative of their population, but also I think the number of other sequencing studies that are being done in different countries, such as in Singapore, Qatar, and other parts of the world, really is driving us to looking towards data sharing so that we can access the information that's generated elsewhere to inform our diverse population and ensure that we've got representative reference genomes actually for diverse populations, and this goes across all of our testing, both in the NHS itself. So, for example, even in pharmacogenomics, that we need to make sure that we're looking at different variants that occur more frequently in Caucasians compared to non-Caucasians, for example. But in NHS England, we have established a legal, ethical and equity board for genomics that is actually looking, and so we're working with the Race Health Observatory on any inequities in access to testing in our diverse populations in England. I think we collect the data that we actually need to be able to analyse it, but it needs to be looked at in detail, and then alongside strategies that enable us to increase access or understand some of the barriers to why sometimes individuals are not coming forward to being tested. So I think there's both on the research side, but on the actual healthcare side, we have to be really mindful. And also in some of our solutions that might be digital, we also have to recognise that not all people in our population can access digital information. And we have to be mindful of that.
Thanks, Sue. Adam, did you want to come in on this from a UK Biobank perspective?
I think most of the points of it have been covered already, actually, Sarah. So I think that's fine, unless there was something particular you wanted us to highlight from UK Biobanks.
No, I think there's been a question asking whether there are gaps in representation at UK Biobank that might affect how research or treatments apply to different communities. So if you want to,
so that's a great point. Yeah, so I think the biggest thing was that, of course, UK Biobank was set up very much with trying to get as much heterogeneity in the cohort as well. But the reality is initially there was only about 6% that were non-white British represented within the cohort. So although there are kind of large enough numbers to do certain analyses, as Raghib has rightfully highlighted, is that it's not sufficient for a lot of rare conditions and diseases as well. So, I mean, it really does open the opportunity of how you can kind of use UK Biobank for a lot of analyses, but that the importance of kind of validation and replication in other cohorts, whether that be UK-based cohorts, but also international cohorts where these certain populations may not be a kind of a minority, and in fact, in those groups.
and while I have you there, Adam, just a follow-up question that's totally unrelated, from Catherine Ramsey, who says, did I understand, Adam, correctly that 40% of individuals diagnosed type 2 diabetes actually had type 1?
Yeah, so that was the findings from that highlighted in that paper, and again, that was specific to that age group. I think that link was on the slides for that as well, to share that paper from 2018.
Great, thank you. And Raghib, someone who says they're an early adopter of Our Future Health, working with the data. Are you able to provide an update on when your team will provide a cohort profile article? I can't pretend I know what that actually means, but perhaps you can tell us.
So it's a paper that is normally published. It's normally published once recruitment is complete, but because Our Future Health is already so large, we have planned to publish a profile of the baseline characteristics of the cohort, so their demographics, some information on risk factors, prevalent disease, etc. So, but it's a very timely question because we have submitted that paper now, and we hope it will be published in the coming months. There is a commentary we published in Nature Medicine recently, which is available online as well, but it doesn't have all the baseline characteristics.
Great, thanks for that. Okay, then someone has asked, is there any coordination between the programs to prevent unnecessarily duplication or uncontrolled sharing of my data? So this is someone who's signed up to everything or is just sort of worried about data sharing in general. Raghib, perhaps you can go first. Joined up thinking, terrible cliche, but yeah.
I mean, in terms of participants, we discussed a bit about overlap earlier. I mean, Our Future Health is primarily a healthy volunteer or population-based cohort. Whereas Genomics England is obviously mainly a hospital-based or patient-based cohort, so there's very little overlap between those two cohorts, and we discussed Biobank already. But where there is duplication, there will be an opportunity in the future for us to be able to identify those people who are in different cohorts, because they're all linked to the NHS databases. So if we're using the NHS number, we'll be able to identify those people. And we do meet regularly with both Genomics England and UK Biobank, and are keen to avoid both duplication of effort, but also to make it as easy as possible for researchers to use the appropriate resource for the research question that they have in mind, and also for participants to know how their data is being used.
Great, thanks for that. So everyone's asking their questions anonymously tonight, so I never know whether I'm the same person has asked about 30 questions or it's different people. But anyway, someone has asked, digitizing everything is neither inclusive nor equitable. Could discuss that part. There are many people in the UK who are not able to go 100% electronic, either due to economic, technical infrastructure, or physiological issues. Paper copies of forms, etc., should still be made available. I can see Sue nodding vigorously, so we'll perhaps go to Sue first for an answer to that.
Well, I think I made a comment on this a few moments ago, Sarah, that it's the comment is absolutely right. We still have to ensure that everyone can equitably access, particularly in healthcare, everything that is needs to be available to them. So, in all instances, the needs of people who are less digitally able for a variety of different reasons will be taken into account. So that's why I was nodding vigorously. Even though we will become increasingly digitized in terms of how we might access some of our sort of records. But I think it's quite interesting, even in our hospitals now, that have, for example, patients can access their results digitally. Often patients are given paper results at the same time. So I can't imagine that practice changing. I think what's interesting is that the whole debate around what patients might expect in terms of their genomic data when it's so large, and how that might be accessed. That having been said, as we know, and Chris will know this through the 100,000 Genomes Project, when people asked for their whole genome sequence data, that was made available to them in digital media. And so I think we have to, at the end of the day, whether it in terms of the health service, we're there to serve the population that the NHS in England serves.
And does anyone else want to come in on this? Raghib, how do participants in Our Future Health, is that all done online, or can that be done on paper?
So currently it is only online, and it is something which we recognise does mean that some people can't join. Of course, it's something we will address in the future. One of the reasons it hasn't been prioritised, partly because of resources, but also, I mean, from the figures we've seen, I think it's 98% of people aged up to 65 have internet access and or smartphone access. So it's a relatively small proportion of that age group, and our program is focused, and even above that, it's something like 90%. So it has become relatively rare now that people don't have access. Of course, there are other accessibility issues, because of disabilities, which we also need to address. So it's certainly part of our plan to address that, so that anybody can join while we're still recruiting participants, and we will bring in more of those opportunities in the coming year.
And
I was just going to add in there, I think Raghib touched on a good point in terms of difference in the kind of age groups as well. That does have some factor to this. I guess in UK Biobank's perspective, it's coming from the other side, is that we're trying to digitize certain aspects that have been paper-based for many years as well. But I think we're still learning with our participants and doing a lot of kind of participant feedback and advisory programs, both through letter-based postal contact and emails. And I think that is just an example of ways that we can continue to work together across these different programs to come up with kind of solutions that are going to work potentially, things that we're, again, not duplicating efforts, but potentially looking at how they can be adapted for each of the programs as well.
Okay, I will move on. Oh, sorry, Raghib, you wanted to come back. Sorry, you're on mute. That's it.
Yes, I mean, just in going back to the early question about inequalities, I mean, it is something we're very conscious of. I mentioned, the efforts we've made, not just in terms of ethnic diversity, but also socioeconomic deprivation, because there is a danger with these kinds of studies. You mainly get the worried well. People are interested in their health, but are actually in good health. And we have found, looking at the prevalence of various risk factors in our cohort, that we haven't got that. We have got a fairly representative sample. If you look at things like the prevalence of obesity, diabetes, heart disease, mental health disorders, they're fairly reflective of the UK population. So that's really important for us to ensure that it doesn't increase inequalities.
Great. The next question is for Sue, and someone has asked, the implementation plan for genomics lasts until the end of this year. Will there be a further implementation plan for the next 5 years? You may not be at liberty to tell us. You may not know, but...
So actually the strategy was published in 2022, so it's a 5-year strategy and doesn't end to 2027. That having been said, of course, there will be a 10-year health plan, a 10-year cancer plan, and the life sciences sector plan. And we expect in all of those there will be, something related to genomics. So whilst the current strategy will still be active, it's possible that a new strategy will emerge.
Great, thanks for that. So we've got a question about the sort of security of data. It always comes up at these sorts of events. So given the high volume and sensitivity of genomic data collected in clinical and research settings and its potential to directly or indirectly identify patients, what security and governance measures are in place or required under UK regulations to safeguard the rights and freedoms of individuals? How is access to this data evaluated to prevent misuse or unauthorized access? In the context of the data minimization principle, how is it ensured that only data relevant to a specific disease or research purpose is used? So there's quite a lot to unpack in that. And I know from many events we did at the Genomics England in the early days, that a lot of work was done around this. So I'm perhaps going to go to Chris first about the sort of security of your data.
Yeah, thank you very much. Yeah, it's a really important question, and it's something that we look at constantly within Genomics England and within the executive as well. So there are numerous layers to this. We comply with all the natural regulations around being a data processor and then a data controller as well. There's the nature of genomic data as a especially characterized data set as well, which is really important to bear in mind. Of course, internally, all staff go through relevant controls and training. On the technology side, we deploy perimeter checking tools. So if someone is trying to probe the perimeter of your technology estate, we have tracking and checking of that, which kind of flags whether that is occurring, for example. And we have process in place to ensure we update servers, update software to reduce vulnerabilities. The other side, I think, of this as well is just in terms of who's accessing the data. We have our access review committee, and I imagine OFH and UKBB have similar things in place where researchers and participants critically sit and look at who is asking for access to data, and they sign off access to the actual environment itself. And that's true for international researchers and industry as well. And that process gives us assurance about an insight into participant comfort with who is accessing the data, and that it is for the purpose, critically, that Genomics England was set up to facilitate.
I can.
Great, Adam.
Yeah, so I guess just to kind of reiterate many of the same processes in place for UK Biobank, but to also just to highlight as well that I had mentioned in terms of the data being so accessible, that doesn't mean freely available, and that there is this vetting process and checks in place and also training in place for researchers to be able to have access to the data. The other thing to highlight is that the whole genome sequencing, whole exome sequencing data within UK Biobank has always only been available within a cloud-based research analysis platform that we have as well, with additional security checks in place. So that has added to the additional security measures. And it's just to mention too that there's also, even with the kind of the data that we hold related to imaging, for example, de-identification processes are in place even for images to, for instance, deface or remove features that may be identifiable as well.
And Raghib, I guess when you're setting up this and you can follow other things, there's a lot of the heavy lifting's perhaps been done for you in terms of practicing up your processes.
Yes, we were able to benefit from the experience of other programs, including GELA and UK Biobank. But for us, as with the other two programs, the security of our data is really our highest priority. Millions of people have entrusted their data to us, and we want to make sure it can only be accessed by those who have the right to access it. And that goes through an independent access process. The data is only held in our trusted research environment, so that is an additional kind of security feature. And we have a number of features. I can't go through all of them in the interest of time, but just to say we've been audited and we've passed our ISO 27001 information security audit recently without any findings. Also the NHS audit, which looks at how we're complying with the data sharing agreements, and also passed that with only low risks identified. So we're something we keep a very close eye on, and we'll continue to do so, as in we're very conscious of the data that's been entrusted to us and make sure we're using it in the right way, or it's being used in the right way.
Great. We have a question from Vincent Straub for you, Raghib, saying, says, I'm currently studying participation bias in OFH. Is there a particular disease trait phenotype where there may be bias that you personally would be interested to find out about?
That's
put you on the spot.
Yeah, that's an interesting question. But I think I mentioned earlier, you're always concerned in these kind of studies that you will attract the wired well, and so you will have actually relatively much healthier people in the general population. So that kind of selection bias, the healthy volunteer bias, is common in these types of cohort studies. We haven't looked at every characteristic, but from some of the basic prevalence characteristics we've looked at for common risk factors or common diseases, it's not that different to what you'd find from a representative sample for something like the Health Survey for England. So we keep a close eye on this, but as from what I've seen so far, it doesn't appear to be a significant problem. We're getting a relatively representative sample. Having said that, there are some groups, who, particularly those with disabilities, who would find it harder to join the program in the first place, and that is something which we do need to address to ensure that they can take part as well. So that is a bias which I'm conscious of and something that we need to address.
Great. So we've got a question about the use of polygenic scores. So that the person says all of 4 of the speakers mentioned the use of polygenic scores in the context of their respective projects. There's a lot of justified skepticism about polygenic scores, not because they're completely without use, but because they're often misconstrued and misrepresentative as a equivalent to traditional genomic data, especially in direct consumer products and services. Can the speakers reassure us that polygenic scores will be used in a rigorous and duly skeptical way? So who wants to go first on that one? I think we'll let Raghib off the hook for answering this one. He's just done one. So we'll go to Chris first.
So we don't currently do polygenic risk scoring as part of our programs at the moment, and we agree we're waiting for that evidence base to come through And that's why it's so important, I think, that you combine it with other risk scoring to ensure its accuracy and its relevance, which is why, I mean, I might let Adam come in a minute. They did it alongside QRIS scores, for example, with cardiovascular disease, and that's the NHS's pilot of it. So what we see is that it has a possibility to be part of that lifespan use of genomics across the population in the medium to longer term. But whether it's ready for clinical application right now, for example, is one for Sue and others in the kind of commissioning seats in the NHS and Department of Health.
So should we go to Adam and then to Sue?
Yeah, and I think one of the advantages of being able to derive these and also to explore them within UK Biobank is to kind of have a first look at what potential impact it will have for different diseases. And I think the point of kind of what added benefit do they have over existing risk scores is a really important area to be focused on as well. So I think there's still a lot of work to do within the space to fully understand that. And I think it will be dependent on certain diseases as well.
And Sue.
Yeah, so I've got two parts to my answer. The first is within some of our genomic testing now, especially in the cardiovascular area, we already include some SNPs, not the full SNPs in some of the assays that are currently available, but that actually also enhances some of the genomic information that can be generated as part of the interpretation of that of other genetic testing in some cardiovascular conditions, particularly in familial hypercholesterolemia. For the NHS, everything goes through a very rigorous evaluation through, as I mentioned earlier, scientists and academics who are part of the test directory evaluation. So very targeted use at the moment. And then secondly, with Raghib, and I think Raghib has such a, it's such an amazing resource with also the ability to feed back to participants. We have the real opportunity to evaluate the feedback of polygenic risk scores as part of an integrated risk score with other scores that are used in diabetes and in cardiovascular disease to one, understand what it actually means and what the impact is on primary care, but secondly, to establish the right pathways that need to be put in place if individuals require other investigations. And so, for example, when we start to move into cancer polygenic risk score feedback, then there will need to be access to some additional screening activities. So I think our plan at the moment is to work really closely with Raghib and his team because of the numbers that they have through this, through polygenic risk score testing, to look at this very carefully and understand impact, outcome, and also establishment of pathways so that no patient would be in any way disadvantaged by whatever polygenic risk score they have as an outcome.
And Raghib, do you want to have the last word, or have they said it all?
Just as I mentioned in our specifically to answer this kind of question, to produce the evidence base for these new approaches, so using particularly integrated risk scores where we combine the genetic and polygenic risk score information, but also polygenic risk scores where they're appropriate in isolation in the coming years. So we start with a position of equipoise, and we want to know both whether they produce better clinical outcomes and are also cost effective, and as Sue said, can also be implemented in the NHS.